So the triage protocol, we've been talking about it in general. This is what will determine who will get life-saving critical care and who will not. It's a very upsetting notion to people. It is abhorrent to many people. Why have you not had to, but why have you drawn up the plan?
Well, I think it's important to take a step back and recognize that when you have an overwhelming surge in demand for critical care, which we haven't yet faced in Ontario, but we are heading in that direction, you have a situation where simply if there isn't enough resources for everybody in the system, ultimately there is a decision to be made about who is going to get those resources. We are very hopeful that we won't get there. But when you arrive in a situation like that without a plan, we saw that the results of that in other parts of the world about a year ago in Italy, for example, and in China, where people at the bedside have to make up rules on the fly with no guidance. And what ends up happening is some very crude rules and things like age limits and very simple considerations of medical problems. And that obviously leads to problems related to fairness and equity and sort of subjectivity and bias, which is really not a thing you want to be doing at a time like this. Instead, the plan that was created was one that would really try to help make sure people keep focuses if we need to do this, keep the focus on the chance that that person is going to benefit from the critical care. In other words, will they survive even if they get critical care, or is their probability of survival very, very low? So that's the main focus of this, was to try to make sure, number one, that we get as many people to live as possible, but also try to be as fair as possible, that people are not going to have, subjective judgments or quality of life judgments or other things like that interceding into the decision and the judgment about whether or not they should be getting critical care.
Decisions made on the part of individual doctors remove that burden really from them by having this framework that you've put into place. It's a 32-page document, as I understand it. Obviously, we don't have the time to get into every single detail, but can you explain so that we understand what it looks like, the framework, and how you would go about making that decision?
So again, it's not a document that says who to include and who to exclude it. If there are enough resources for everybody, everybody will get resources. It's simply a prioritization scheme where, very much based on somebody's chances of surviving with critical care are taken into account. So again, if there is a situation where we have to limit who can receive critical care and not, that critical care will continue to be offered to people who can benefit from it the most. So the way that's done is that it's an assessment by two independent physicians based on as much clinical guidance as we can give to help aid that judgment. And again, the aim there being as much as possible to keep the focus on mortality risk as the only criterion that we're concerned about.
So just to jump in, this is the assessment of short-term mortality, as I understand the term, the likelihood of a person's dying within 12 months. This is what you're seeking to determine with this list of criteria.
That's correct. And it's really a guidance so that, if somebody comes in, we're all relying on the same pool of resources. So whether you come in with a car accident or a heart attack, or if you have advanced cancer, that everybody's being compared to the same rule, compared against the same criteria. That people won't be treated or given preferential treatment because of the illness that they have or whatever condition they might have.
In the crudest form, does it come down essentially to a score? If there are two people and somebody has a higher chance of surviving 12 months, that's the person who's going to get the care?
Yeah, so it would have to be a very substantial difference for one to be prioritized over the other. So we're not looking at very small differences. This is really trying to come up with broad categories, understanding the limitations as well of the tools that we have, but making sure that, and if there is a prioritization scheme, that it's based on something rational, something objective, data.
The measures then, so the decision to determine who would get the care, but I'm also wondering, is this a scenario that you've imagined where you might actually have to withdraw treatment from someone who is presently getting care, someone who is on a ventilator, and you might decide that there is someone else who would have a greater likelihood of survival and therefore remove that
I don't think anybody wants to get to that point at all. We're hopeful that we'll get through this just by surging capacity and moving people around. the plan that's been circulated at the moment does not involve that at all.
Okay.
However, in a more extreme situation, there is, that would be something that people have asked about and talked about, because it's a question of fairness, that applying different rules to critically ill people who are already in the ICU versus outside the ICU is unfair. So the new people coming in, predominantly people racialized, people with less access to critical care, and people who actually have a very high chance of survival, should probably get the same priority as anybody else who maybe had better access and who is not as racialized and not as from lower socioeconomic status.
You've raised it.
It's not fair to prioritize people, I think, along those lines.
You've raised such important points, because obviously there are huge ethical considerations with this issue, and there are strong criticisms of the plan as it's been drawn up. For example, a disability rights activist and a lawyer described it to CBC News as a raging, cruel disability discrimination, obviously strongly opposed. What protections are in place? There's
absolutely zero consideration of disability as disability. It's purely on mortality risk. There's explicit language in it not to use disability as a criterion, and for the simple reason that people with chronic stable disabilities are not actually at substantially elevated risk of dying, of having higher mortality. So again, somebody who has an advanced illness where their chances of survival may require assistance with some things as a result of that advanced condition. And they may have the same level of disability as somebody else who has a very low mortality. Those two people would be prioritized completely differently. So again, and there's explicit wording in there not to use this for people under the age of 65, not to use it for chronic stable disabilities. No iteration of this document has ever focused on disability, and that's a really important point. This same document was proposed and accepted for use in other parts of the world, including Quebec, with the enthusiastic support of disability advocates, and I just want to make sure that everybody knows that.
Thank you. We had a couple of people talking about this very issue on our network last night, and one of the doctors who was interviewed, the quote was, "We're all losing sleep over this." Very much worried about this coming into effect. It has not yet. It is in place. It's there. As you said, it's important to have a plan. It has not been enacted yet. How close is Ontario to having to do that? And do you foresee that it is inevitable, or is there any way to forestall it?
So we are doing everything we can to avoid this. And again, I often tell people that it's really an option of last resort. Nobody wants to get to this point. I've never been at this point in my life. These are not conversations I want to have. So we're doing everything we can to forestall it. The only thing worse than having a plan like this is not having a plan like this. How close are we? Mm-hmm. That is a tough question to answer, because we're surging. We're constantly trying to add capacity. Unfortunately, COVID is also surging, and COVID is taking more and more people. People are sicker. People are staying in the ICU for longer. That's going to put a lot of strain on our system. We're already at unprecedented levels.
Are we talking days or weeks, Dr. Downar? Days?
It's very tough to say, but I think if we continue to spike, and the modeling shows, numbers, if the numbers get up to 3,000 critically ill people from COVID alone, we only have a little over 2,000 staffable beds right now for the whole province for all critically ill people, and there's at least 1,000 non-COVID cases that are going to be in at any given time. So again, it would be very hard to see how we could manage that. How close are we? It's not going to be in the next few days, that's for sure. We've done, I think, a really good job of adding capacity, and again, we're hopeful that with some of the changes, the newer methods, and vaccination, public health, observing public health rules are the key to forestalling this. So people at home, please, if you're eligible for a vaccine, if you're able, particularly if you're in one of these hotspots, to go to a pharmacy or go to a clinic and get that vaccine, please go and do it. And also make sure to continue to observe these stay-at-home order provisions. These are really, really important, because that's how we're all going to get through this together.